So I'm Kristina Mirabeau-Beale. I'm a board-certified radiation oncologist practicing with 21st Century Oncology in Southwest Florida, and I'm based at the Regional Cancer Center and part of the Breast Program Leadership Program. Generally, it means to be immune compromised that your immune system is not functioning in an optimal way. And that can be for a number of different reasons, sometimes due to our treatments, whether chemotherapy or radiation, sometimes also due to the disease process itself. So in our patients, having an active cancer diagnosis sometimes can compromise their body's ability to mount an immune response to fight infections. That's a complicated question that we're still learning about day by day. The data suggests that patients who have an existing medical condition have worse outcomes, and that includes both an active and prior diagnosis of cancer. We know cancer as a whole is a very heterogeneous group of diseases. And so obviously patients who may have a lung cancer, for example, or a history of metastatic cancer and are on maintenance chemotherapy or immune therapy would obviously be higher risk patients than, for example, some of my early stage breast cancer patients who could be treated with surgery alone or surgery in a combination of radiation. But I think in general, especially since this is a novel agent and we are still learning both its infectious qualities and how it affects different hosts. In my practice, I'm encouraging patients to use an abundance of caution and kind of warning all cancer patients to kind of be extra cautious and do things like the social distancing and maintaining close contact with their physicians and those sorts of measures. My advice to patients undergoing radiation therapy very much depends on kind of where they are in their treatment journey. And this has become a very complex issue that has involved a lot of multidisciplinary discussions with my medical oncology colleagues and my surgery colleagues. So for some patients, for example, where potentially they could have gone straight to surgery and then would see me for radiation for like early stage breast cancers, for example. We now have consensus guidelines from our professional societies that encourage us to put those patients on anti-estrogen therapy in an attempt to delay them actually needing radiation therapy. And that's also because a lot of those surgeries, some of those are being kind of deprioritized now in an effort to minimize the strain on the healthcare system while there's this evolving need for respirators and inpatient beds and that sort of thing. Another piece to that is the throughput through a radiation therapy center. Patients are treated daily, Monday through Friday, for a number of weeks in some situations. And we're encouraged to try to critically evaluate that so we can minimize the number of patients, for example, who may be coming through our department and put themselves at risk, put our staff at risk, just in case we have a COVID-19 patient. So far in our centers, we have not had to treat a patient with COVID, but we are taking a lot of preventive measures to make sure that we kind of streamline our check-in process and minimize number of patients that are in the department at a given time. And I am actually having proactive discussions with a lot of my patients before treatment to determine whether their radiation therapy can safely be delayed until we kind of get our bearings with the surge capacity of this pandemic, versus which patients need to be prioritized and get treated as soon as possible with some of the safety measures, like I've mentioned, that we're trying to do to mitigate risk within our department day to day. It's become very individualized. It's interesting how this has unfolded over the last month and a half or so. I actually think my patient volumes, my clinical practice tends to be predominantly breast and GYN cancers, but I also treat a fair number of lung and palliative cases in general. And I feel that in early March, for example, there was an initial almost surge volume of patients who had just had their surgery and were ready to start. Maybe we're hoping to delay treatment, but given the uncertainty, kind of wanted to get the radiation done as quickly as possible. And so saw a lot of consults very rapidly, and then also was very aggressive about using short courses of radiation therapy where appropriate, so that patients could start and finish that part of their cancer treatment while we were still, fortunately had a very contained or had very few, if any, cases in our community. But then as things have evolved, not just increased numbers of cases of COVID in our community, more healthcare workers in quarantine situations, and then now more recently the stay-at-home order. Now we're being very case by case and kind of judicious. There's some cancers that can't wait: head and neck cancers, medically inoperable lung cancers, symptomatic things like bleeding GYN cancers, and those patients are given priority in terms of starting right away, with, again, some of the careful measures to try to minimize exposure to the patient during treatment. But in other cases, I'm trying to counsel patients that, we have good supportive data, that we don't compromise their overall oncologic outcome if we, say, have an early breast cancer patient take an aromatase inhibitor for 3 to 6 months. So it ends up being very case by case. And there's a lot of anxiety for a bunch of patients for that reason. So trying to be as evidence-based as possible when the evidence changes day to day is obviously an obstacle that many of us aren't used to. So again, this will come down to what the definitive treatment was for your cancer or a patient's cancer. We think of things a little different. For example, if they've had surgery and then radiation's given adjuvantly to kind of prevent a recurrence, versus if chemo and radiation therapy together were used as the definitive treatment and the patient, has what we hope is dead and dying cancer still in their bodies, but it's very important to get that first post-treatment surveillance scan to assess treatment response. A lot of departments, and many in our community included, are very much not doing screening studies at this point, but they are still trying to maintain throughput for our diagnostic scans and treatment follow-up scans. So I think it very much becomes an individual discussion between patients and their doctors. Different types of cancers have set intervals of when we should do post-treatment follow-ups. And there usually is some gray zone. So for example, I tell some of my breast cancer patients, even though it can be a convention for us to do a post-treatment mammogram within 6 months of finishing their therapy, the American College of Radiology actually has some heterogeneity in what the guidelines say are absolutely needed. And so long as they don't fall behind in their annual mammogram, I think it's reasonable to delay that first post-treatment surveillance mammogram in times of COVID-19, where we're encouraging patients to somewhat triage more routine surveillance procedures.